Hi, my name is Keisha. I'm the new nurse consultant for haemoglobinopathies based at the Brent Sickle Cell Centre. I'm just going to be giving you a community update in regards to the service at Brent and just how we can work collaboratively in looking after these patients. I'm going to aim to share my screen now. Um, let's see if we can get that up.
Your share, yep, brilliant.
Are my slides up properly?
They are.
Okay, excellent. Okay, so I might as well go to the next slide. So this particular document was about improving specialized care for haemoglobinopathies in England for November 2028, which sets out the current commissioning plans in the UK and also how care is distributed out. So there's lots of information on the screen. Basically, we have sort of like a triangular structure where at the bottom we have local providers, your local hemoglobinopathy teams who um, are continuing to develop some aspects of their service, but they need additional support. So they feed into specialist hemoglobinopathy teams, which we are all a part of. So uh, Brent is under London Northwest, which is a specialist hemoglobinopathy team, and we provide support to places like Bedford. There are 24 specialist hemoglobinopathy teams throughout England, and they then feed into the the hemoglobinopathy coordinating center, which Hammersmith is. So that's the direction of travel, and the coordinating centers are funded basically to provide support for the SHTs, lots of leadership and education, which we're doing today for our community and primary care colleagues. And from the HCC leads into one panel, the hemoglobinopathy panel, and this is led by King's and Guy's and St Thomas's jointly. And so at that level, what happens, we have novel treatments being discussed, options for individuals with complex care needs, and just an overarching responsibility for the services at a regional and national level. I'm going to skip these other couple of slides just for time. I think my medical colleagues have really gone through a lot of the pathophysiology and spoken about the hemoglobins. So I'm not going to go into this too much. It's mainly to discuss the Brent Center, which is the Central Middlesex Center, is one of the leading screening labs in England. So it's the secondary lab. So the first screening lab for this side of England is Great Ormond Street, and the results that are irregular or unusual then are sent to the Central Middlesex site for confirmatory testing. And so I think our colleagues have gone through this. So every adult should have one pair of beta globin chains and two pairs of alpha globin chains. I'm just going to go through for our screening results what usually tends to happen. So in our newborn screening, it's expected that our newborn should have about 90% of fetal hemoglobin, a little bit of our A1 and A2 sitting around. By the time a baby is about 12 months of age, your fetal hemoglobin already starts dipping down, and then your alpha or your hemoglobin A, sorry, your hemoglobin A starts increasing. And an adult patient who has normal or usual type of hemoglobin will have less than 1% of fetal hemoglobin and about 95% of A, and the rest will be A2. So with our screening results coming in, usually this is what our newborn screening results are reported into us. This is what they look like. So a baby with a screening result of F and A usually is a normal or a usual result unless the baby is transfused. And the same if it's A and F on that screening result. But we can't exclude beta thalassemia, which gets picked up later on from about 12 months of age. And so for screening results for carriers, um, babies who are sickle cell carriers, that result looks like F, A, and S because obviously the baby's a baby and will continue to have fetal hemoglobin circulating. And so if we, as long as they're not transfused, then they should, results should have fetal hemoglobin, a small bit of adult, some adult hemoglobin, and whatever that unusual hemoglobin type is, if it's S, C, D, E, or any of the other unusual. We've got over 1,000 variants of hemoglobin. It's important. I put an asterisk at the bottom. If a baby's result is FA plus band, then it means that we need to do a bit more investigation. And it might be an unusual type of hemoglobin that we haven't identified yet within our labs. So the carrier reporting for this is the newborn screening. As I said, if a baby has got a result that is HbFS, there's a few possibilities. This baby could have sickle cell anemia, where we've got two S genes coming in from both parents. It could be sickle beta thalassemia, or it could be a combination of sickle plus hereditary persistent fetal hemoglobin. And so we'll have to repeat this blood sample maybe 3 or 4 months later. Usually we tend to go for a venous sample. For a baby who is found to have other types of sickle cell disease, we can have S and C. So obviously the F fetal hemoglobin will be present, but you would have the heterozygous S and whatever the other unusual hemoglobin, if it's C, D, E, etc. So for babies who are born with just fetal hemoglobin, there's lots of questions. Where you've just got F onlys, was the baby born prematurely? It could be possible beta thalassemia major, where you've got two thalassemia genes, beta zero thalassemia genes coming together. Possibly beta thalassemia intermediate, where you can have beta plus for one parent and beta zero, or baby could have a hereditary persistent fetal hemoglobin, or again, a novel type of mutation that we just haven't come across yet. Other reports that we tend to see are, unusual ones, and we have to question whether or not the baby's been transfused. Now, there's a clear pathway in the screening program that babies who are transfused have a blood spot done before transfusion, before it's sent off for newborn screening. But sometimes, for whatever reason, that may not have happened. So the question of transfusion is always um, around. And then for these babies, further investigations would need to happen. If a baby has been confirmed to be transfused, we tend to repeat that blood test about 3 months or 4 months later. So these are carrier status in the adults. I'm sure many of you know about them. And the next slide is just about frequency and how often these unusual hemoglobins come up in different ethnic groups. These slides will be available, I think, after the training. So in the UK, the prevalence at the moment, sickle cell disease continues to be the most common occurring at the moment. And in the UK, over 300 births for sickle cell disease annually. So just to talk about our role in the community and what we do. So for community nursing, our aim and our goal is to really, as we listen to Dr. Anderson speak about self-management with some of our patients. So the main goal is about encouraging self-management and a more general health promotion. So raising community awareness of sickle cell disease, management of screen positive pregnant women. So our service is linked into the antenatal screening program. And so we counsel at risk couples, we counsel women who are on their own, who are carriers of unusual hemoglobin, and discuss the options for management of an at risk pregnancy and make relevant referrals for prenatal genetic diagnosis if needed. Coordination and adoption of multidisciplinary team approach, always discussing follow-ups and any complex care needs in our MDT, which is informed by our holistic approach to healthcare and especially valuable in the management of pain, as you've heard from the last speaker. So what we're trying to do is to aiming to avoid omission or unnecessary duplication, a patient held shared care record. So continuing with the role of community nurses. So again, we're trying to support our patients to be empowered, trying to develop personalized care plans for these patients. Our previous speaker spoke about goals and really encouraging our patients to have something to focus on outside of pain and any of the other complications that may be happening to them, and how we can best support them. So agree goals, identify what sort of support they need, and developing some action plans to see them along that pathway, that process. Lots of education and self-management skills for these patients. Starting next week, Monday, on a weekly basis, one of our SHOs will be doing some education sessions for patients once a month, tackling one complication at a time. And I think it's really important that our patients have more education about their condition. At times, they can be patient experts about their pain and how they believe that should be managed in hospital. But in my experience, many times they're not experts on the condition and how it works. And so we're hoping to sort of improve that. This has gone out on our social media platforms, and hopefully we can. I'll ask Ralph to send the link out as well, that maybe you can share with your patients when you go back to your respective surgeries. So looking at how to minimize the risk of crisis, complications, how to manage uncomplicated pain at home, what are the suitable analgesias they should be taking, any sort of non-pharmaceutical methods that we should be, you know, looking at to try and support them. And I guess the aim is sort of hospital avoidance and really trying to reduce any disruptions to the patient's life. So, again, holistic approach, recognizing the social disadvantage and maintaining our quality of service. So, offering advice on activity and rest, nutrition, prevention and early treatment of infection, general health and well-being, reproductive issues, as we talked about, looking at prenatal diagnosis and possible referral for pre-implantation genetic diagnosis if needed. An assistant with benefit and welfare. And again, I think Jeremy touched on this. A lot of the triggers that bring our patients into hospital, have to do with their social economic backgrounds. And so looking at how we support them with it, whether or not it's writing letters to housing, helping them to complete the relevant DWP forms, etc., etc., and signposting them to local support groups that are in the area, where they can share their experiences and maybe get information and other advice and support. And again, all the work that we do is audited, and, a lot of the information and the data has to be fed back into NHS England at a national level. So we look at how we're improving the care for patients. Um, Again, I mean, facilitating admission when it's needed. We carry out home visits so we can see patients at home. They have access to us to contact us if they're ever concerned, where we can discuss maybe medicines management with them, and if appropriate, signpost them to A&E. If it's a difficult or complex situation, contact the emergency services on their behalf. But making those sort of triage decisions at the right time. So we're trying to prevent readmission to hospital. So again, educating the patients and their family about when to seek medical help appropriately, and looking at the areas. Dr. Awasabi Sawi, he discussed some of the complications that we would be concerned about, um, and also, sort of support early discharge from hospital as needed, and encourage them to continuing that good care in the home setting, looking after themselves well. So I guess the question is, as GPs, how do you help us to sort of support the patients? I think access to primary care has been highlighted. If we look at the standards for clinical care of adults with sickle cell, the 2018 version, there was highlighted there was a barrier to effective treatment and continuity care and follow up after discharge. Um, many of you have some very good gatekeepers, your administrators, your frontline administrators, and I know that appointments are, can be few and far between. I think just highlighting the importance of, some of the complications that we might deem to be urgent or a little bit more complex that might need your input, but that also requires education of those members of staff as well. Looking at alternative models of care within the community. For instance, specialist service involvement in providing home or daycare management. So at Brent, next door, we have a medical day unit at CMH where our patients can contact the medical day unit between 9 and 11. And if they are identified as having a non complex sickle cell crisis, they can come in to have some pain relief, very similar to what Dr. Anderson was speaking about. So, a couple of doses of injection where they can have hydration, a sort of quiet, calm environment to be able to rest, to prevent hospital admission. Um, we're here today because we want to, educate and continue to have sessions like these to improve the understanding of sickle cell. And yeah, just looking at, we'd love to hear questions and any suggestions that, as our primary care colleagues that you have into how we can work better together. And I've put, is there a role for community annual review? Just putting a little drop in throwing it out there. So our patients require annual review, looking at things like vaccinations, echocardiograms, uh, sending them for ophthalmology review, and just putting that out there. Is there a role for some of this to happen in the community? I know you've got a big caseload. Is there a role for someone like myself coming into your GP surgery and doing that jointly with you? There's lots of suggestions, but we'd love to hear what you think. So communication and collaboration. I think, we should, for us as specialist teams, should provide support and training for you guys, which is what we're doing today. But also for our primary care team should be responsible for infection prophylaxis, including prescribing of regular antibiotics and vaccinations. So making sure our patients are up to date with their vaccinations, and really just fostering good communication between us. And I mentioned this thing about a handheld record, but that might be a little bit old fashioned, and maybe we should be looking at ways of holding that on a virtual space in an app. I know they're developing a lot of apps at the moment. So I talked about documentation. I mentioned about this prophylactic antibiotics, penicillin, that our patients should be on, but there are other things as well, folic acid, and some patients might be on other medications, including hydroxycarbamide. So I guess it's just communicating with us and letting us know whether or not patients are collecting prescriptions. And that's really important, I think, also for pediatric patients. I know Dr. Al Musawi talked about the importance of penicillin, especially in the younger years. So if we have children with sickle cell disease are on regular penicillin and parents are not collecting, we need to be aware of these. For us as the team to inform you once patients have been discharged and identify any patients who might require follow up. We have a community nurse who also does follow up with our patients um, via telephone and carries out home visits. I think I mentioned that as well. Um, so for primary care teams to be responsible for documenting and providing repeat prescriptions, which I mentioned earlier, but that I think also includes analgesia. And I know there might be some anxiety towards continuing to prescribe analgesia for patients. I think Dr. Anderson gave an example of a patient who was on a small dose of codeine, but was meant to feel as if he was on a larger dose. But I think in any scenario, if you're ever concerned about the dose of analgesia, it's very easy to send an email to the teams, to the consultant, to say, I'm concerned about this. Are you happy for me to continue to prescribe? And also, we'll continue to do that on our discharge summaries as well. Um, Proactive primary care for sickle cell disease, so early treatment of infections to prevent sepsis. We mentioned about penicillin and erythromycin if patients are allergic to penicillin, up-to-date vaccination, reproductive provision. So early referral into our services if there are patients who you're aware of who already have sickle cell disease, for example, or we know that they're an at-risk couple, to refer them in for counseling as soon as possible so we can make decisions about what needs to happen and if there is a risk to the pregnancy. And general contraceptive advice as you would anyone else. Um, Referral for psychological support. So we have a psychologist that works as part of the team, Dr. Kofi Annie. And I think if you identify patients within your practice that you're concerned about, feel free to refer them into our service um, for follow up with Kofi and really encourage compliance. You know, it's one of the things that I think trigger crisis a lot when our patients are not compliant with treatment, not compliant with attending for their clinic appointments, and sometimes they get lost to follow up. So I mentioned about patient education, which we'll be doing some in the hospital, but you've had a host of wonderful information today. So I hope when you're in consultation with our patients in the next time they visit your practice that you're able to offer some of that information to them. So what we'll be doing both you and us as primary and secondary care is reiterating the same information so the patient hears it from you and they hear it from us and supporting us with transition for our patients, our pediatric patients moving over to the adult service. um, I think that's it. I don't know if there are any questions. I'm going to end my slideshow now.
Thank you so much, Keisha. As you said, there's been some excellent information shared this
Yeah.
afternoon from you and the other presenters. There's a question here, because I think, Jeremy, did you answer Dr. Zada's question? Was that when you said yes, in contrast to another patient?
Oh, no, I was actually just responding to the mention that, my patient was made to feel like a drug seeker after using the equivalent of 3 milligrams of morphine per day.
Right,
Um,
okay. Oh, Dr.
yeah.
Zada, above that did say, do you think prescribing
Oh, sorry.
antidepressants to sickle cell patients in the community would help them cope with
Oh,
long-term psychosocial issues?
sorry. I didn't see the question. I was
No, that's
responding
fine,
to
that's
the
fine.
comment. I, I mean, as a psychologist, so I don't prescribe. I'm not permitted to prescribe. But so just take what I say with a grain of salt. But my understanding of the effects of antidepressants is that there's probably a small cohort of people for whom antidepressants are effective, but that they're prescribed very frequently and they're not really doing very much. Because a lot of the times the things that people are being prescribed antidepressants for has to do more with just living lives that are not very meaningful. Um, and so you can give them a drug, but that's not really going to solve the problem in their life. And so I would say, in general, no, I don't think antidepressants are, there's no quick fix to these things. And they
Thank
don't
you.
people live better lives.
Okay, thank you, lovely. There's a question here. I don't know who it's for, so I'll just read it out. It's from Charmaine Carter. She says, "How are you finding COVID has affected the hemoglobin, you know what I mean, cohort? Noted sickle cell disease is the highest risk of complications and eligible for antivirals from CMDU outpatient service." Did you understand that?
Yeah. Well, I
I don't
mean,
know who can answer that.
I suppose we all have different perspectives. I would just say, from a psychological perspective, for the pandemic, I mean, everybody was shielding, right? And so for many of my patients, I was the only human interaction they had for 2 years, just meeting me for an hour once a week. So I think there was a huge need, and I was awfully busy during the pandemic. Um, um, I think it was essential. People needed human contact, but they couldn't get it because they had to stay inside all the time.
Thank you. Stephen or Keisha, would you like to also answer that question?
Yeah, just to add that our patients have struggled. A lot of them have had to modify their lives quite significantly to cope with the pandemic. Some of them still are, and I think we also need to sort of bear that in mind. With a lot of patients, regardless of what's being said, they still have a certain fear of going out into the wider community because of the concerns of dying, because that's what we told them potentially could happen. So I think all of that needs to be borne in mind. As to the sort of second half of that question, I think related to uh, sort of antiviral therapy for patients who have COVID, and that's if we do have patients who come to us, our patients who come to us with COVID, we do routinely review them, and the vast majority of them will get antiviral therapy on the back of that.
Thank you. Keisha?
Yeah, I don't have anything additional to add, but to agree with them both. I think there is still a proportion of patients who are fearful in coming to hospital, and so what Jeremy spoke about in trying to manage it at home and the pain increasing, we're seeing that. So then now patients are now that are for a period in time the day unit at CMH was closed, and we reopened that pathway now. So we're seeing many patients who probably might have come into hospital presenting that picture that Jeremy showed earlier, presenting to the daycare unit more frequently, trying to avoid hospital admission because there's a fear that's attached to that to the hospital in relation to dying and becoming seriously unwell. So yeah, so I think for GPs to really be mindful of that when patients come in to see them. But I think for me personally, it's about having some sort of discussion with the frontline staff, because many of the conversations and the phone calls we have is about not being able to be able to have an appointment, to going to see a doctor, to get repeat prescriptions. And then when that doesn't happen, the knock-on effect is that people present to A&E. So there might be situations where we may be able to manage someone. If you have someone who generally manages their pain very well, uh, maybe I don't want to use the word responsible, not that some of my patients are not responsible, but many of you would know where I'm coming from when I say that. So you have a patient who is a responsible patient, usually not a patient that comes in very frequently, but is struggling at home. And I think there is scope to say, or give us a ring, give Dr. Al Musabi a ring, give Stephen a ring to say, this patient is coming in, not really wanting to come to hospital. Could we prescribe 3 days of MST for that patient and a bit of Oromorph for 2 days or 3 days to keep them out of hospital? So it's just really thinking about the scope and how things fit in. But the main thing is that we communicate with each other. If you have a concern that a patient is on a massive amount of morphine and you're concerned about it, let's have a discussion, because there might be lots of factors going on that you're not aware of. And I think, yeah, keeping the lines of
Following,
communication
just
open.
following on from what you said, how would a GP contact you? How would they get the your contact details?
So we can I can leave it with Ralph so we can put that up. So for the Sickle Cell Center, for the CNS on call, and for the secretaries, for the consultants, we can send that. There's an email address for the Brent Center as well. So yeah, we're quite happy for people to email us and
And what about the
clarify.
response time? Is it quite immediate, or would they
Yeah,
have
and
to wait
if
for a...
if we ring the CN, if you have the mobile number for the CNS, then that's fairly immediate during Monday to Friday, 9 to 5.
Okay,
Yeah.
brilliant. I don't know. I can't see any further questions. Um, if there are any questions, please do let me know. Otherwise, I will bring the session to a close. Absolutely brilliant, so informative. I'm sickle cell trait. I didn't find out till I was a grown adult,
Wow.
and I didn't really realize the consequences of that. So had I chosen the wrong partner, there could have been consequences for my children. So I think it's really important. And I know within Imperial, that we've had a patient who sadly passed away, and I know that I think it was young Evan that passed away a few years ago. So I just think it's so important to keep you know, the information cycle going and informing our primary care colleagues as well. So yeah, just suffice it to say thank you all so much. We've recorded the session, and so all our attendees today can come back and watch the sessions if they need further information, or to hear the information again. And then we will also, hopefully when you guys forward your slides, we'll put them onto our GP section of the of our trust website so that it can be accessible for our GPs. But yeah, suffice it to say, thank you all so much. Absolutely brilliant. Jerome, is there anything that we need to add?
Hi there. Yeah, I'd just like to express to all the GPs that I'll be sharing an evaluation form for this event, and we'll appreciate if you could fill that in. Once you have filled that in and send it back to us, we will send your certificate, which will give you 2 CPD points.
Brilliant. And I will be sending the presenters also a certificate of presentation, really, and participation, and thanking you very much. So with all that said, thank you all so much, and have a lovely Christmas. This is our last event for the year. Wonderful new year, and hopefully we'll do this again in 2023. Bye-bye all.
Thank
Thank
you.
you all.
Bye-bye.
Thank you.
Bye.
Bye-bye.
Thank
Bye.
you.